So let's go ahead and get started. Welcome everyone in the room. I hope to be out at Shasta County face-to-face with you all in future trainings, but we thought we would start to kick off a series of trainings we plan to do for you all through a two-part webinar. And what we're going to be covering during these two sessions, today we're going to be covering, for the most part, part one, which is framing substance use disorders using a developmental framework. And under this kind of part one, we're going to talk about what we mean by developmental framework, include definitions, include some research on the topic of adolescent substance use disorders. And then we'll move specifically into talking about some risk models, what we call pathway models, around risk and protective factors under a developmental framework, and really hone in on the science of substance use disorders and the effects mainly on the developing brain, keeping in mind the pathway and the complex attributes. And we feel like that's what we'll cover today. We have 3 hours, and I think we might not use all of it, but we'll probably use most of it. I'm going to leave you off of mute, just in case there's any questions as I move through the slides, just so we can make this kind of interactive versus me go through all this stuff and then say, okay, what does everybody think about it? So I think with that, that'll probably get us through the full 3 hours. And then next time we'll cover part two, which is more practice-oriented information related to how we begin to start addressing substance use disorders under a developmental framework. That includes addressing risk versus diagnosis. I should say we are going to talk about medical necessity and like kind of under a framework, but then how do we begin to address substance use risk versus substance use diagnosis among youth, and really next time get into screening and assessment practices, and then therapeutic response. So that's our framework of where we're headed. Okay, so why CARE? Your director, I think Diana and others there, I've given this presentation, or I've given not this presentation specifically, but this content that we're going to be covering about a year ago to directors, county directors, and highlighted the importance around system changes and kind of areas, gaps in the system. And Diana wanted to share it with all of you in terms of putting it on your radar around why this information is important for Shasta County in particular in the work that you do. And really two areas, I think, are takeaways in my discussions that have been really providing you all with current information on best practices associated with system improvement for youth systems, particularly when it comes to understanding the whole continuum of care, and really starting with this notion of understanding this developmental framework piece is key, and then how we practice under that developmental framework with kind of evidence-based and current information across the country, and then in California specifically, that each county is kind of adapting and making their own. So I'll share that information with you all, that to hopefully help better prepare you as a system and as providers. So we call this notion provider preparedness, and really just helping develop your skill sets and your knowledge to help you better address youth and families in Shasta more effectively. So I'd like to start with this as a framework for us. SAMHSA, the Substance Abuse Mental Health Service Administration, they provide a lot of tips and taps. Tips are treatment improvement protocols, and they're on their website, and they're free resources for providers and systems of care. And there's a variety of them, and at the end I'll have some resources for some of the information we talked about. But one of them is on screening and assessing adolescents for substance use disorders, and there's a lot of pertinent information in this tip with respect to understanding the nuances of adolescent and development and what to be mindful of. And so this tip 31, recommends that providers, when working with youth, should have a thorough, a very in-depth understanding of developmental issues pertinent to adolescence. And so we're going to really hone in on that over this next hour or two, as well as health issues, any social barriers, family dynamics and the importance of family, and then existing support. And the health, social, family, existing support, these really get at the risk and protective factors that we're going to be covering in the past models. So I just wanted to kind of lay that groundwork and that framework as to the importance of why we're starting with a developmental umbrella and highlighting pertinent issues relevant to adolescence. And so as we transition into that, it's important to define who and what we are talking about. So who are we talking about when we talk about development? And I used the word adolescence already, but that's just one term, adolescence. Other descriptors that have been used and interchangeably are teens, minors, young people, and young adults. I include young adults given the range of the diverse age ranges that are used federally, nationally, across the state, and even locally across counties. And so if you look at national surveys, like the National Survey on Drug Use and Health, or if you look at Monitoring the Future, they are going to define youth by these two age groups, right, by either 12 to 17 as being adolescents or teens, and then the young people or young adults as 18 to 24. However, if you look at other bodies like American Society of Addiction Medicine, in California specifically, their age range is 13 to 18. If you look at Department of Mental Health in LA County or Substance Abuse Prevention Control in LA County, you'll see nuances and differences of like 12 to 15 being the adolescents, and then the young adults or young people are 16 to 24. If you look at CDC, the Centers for Disease Control, they define youth broadly as 12 to 24. And if you look at EPSDT, the federal Medicaid, and in California we have Medi-Cal pediatric benefit, they define youth 12 to 20, right? And so there's a variety of age ranges that I think is important to consider, but what all of these have, and there's many commonalities across all of these age ranges that I think are important to talk about and really speak to the nuances of youth in general. So we're going to use the term youth throughout, and the term youth that I'm going to cover really falls along the spectrum of 12 to 24. And why? Well, there's a lot of research that support that these age ranges developmentally and these age periods are characterized by significant change, significant growth, and significant maturation across these developmental hubs or elements, if you will, that range from biological with significant change that is happening in the brain and neurologically, physiologically, a lot of pruning that's going on in terms of brain maturation, and so we'll really talk about that today. And you all know that the brain doesn't fully mature or develop till the age of 25, where it reaches full maturation, so hence the 24 marker for still this youth period. Social emotional changes that are occurring with just things like identity formation, the differences and the nuances with relationships with from family and moving more towards peer and interpersonal models and people that youth are developing relationships with that also affect their development, and they're learning a host of skills in emotional ability and management, including impulse control, which is a characterization that we like to kind of hone in on in development in adolescence, besides emotional ability, as well as cognitive changes and things like a lot of growth and maturation around thinking skills including things like decision-making and judgment, and then behavioral, and the changes that are occurring with not only developing life skills in terms of how to regulate their behavior, what we call self-regulation or self-management or self-control, as well as risk-taking behaviors, right, the opposite spectrum, and engaging in a host of risk-taking behaviors. Research points out down here, I have a reference that's in Kaminer. For Kaminer, he's out in Connecticut. It's a clinical manual of adolescents around substance abuse treatment. And it really, I think it's a good resource to have as a provider, just as a developmental kind of perspective around these moving pieces, because what is talked about is what is bolded here around this maturation gap that's important for us to be mindful of as clinicians and providers working with youth, where it states that youth, although all of these elements are in constant flow and fluctuation, youth reach intellectual maturation at around the age 16, but this notion of emotional maturation isn't reached until age 25. And this imbalance between the cognitive and the affective developmental or social-emotional cognitive systems plays a major, major role in this risk behavior process or trajectory, if you will. So it's important to really understand the nuances around this emotional maturity versus cognitive maturity. Decades of developmental research highlight that youth in general across these age periods are considered, or this notion of at-risk population, for developing several social, emotional, and behavioral health issues, right? Not just substance use kind of trajectories, but mental health areas as well. And this age period has really, and developmental research has come up with these areas in which youth across this age span tend to have in common. And here are about 5 bullets that really highlight this age period around age of instability, constant changes, like we talked about earlier with relationships, and their life, like who they want to be, what they want to be, what their life plans are, what their goals are. Those are constantly changing. This notion of being a self-focused age, efforts driven around immediate gratification and happiness, and delaying responsibilities, right? And this interplays a lot with what I just covered with these biological changes that are happening and the maturation in the brain with cognitive and social-emotional aspects. This age of feeling in between, neither an adolescent nor an adult yet, right? So these 12 to 24 really nuance with this in between, like, you know, although adolescents want to be adults, adults don't want to be, or young adults don't want to be full adults, right? So this interesting tension that occurs. The age of possibilities during this developmental period, where it's characterized as youth being very optimistic, right? They have really biased risk perceptions, if you will, around anything bad ever happening to them, and they have a very optimistic view of the future. Be all you can be, the sky is the limit, right, which really reinforces this risk-taking behavior element that's occurring, which is the last piece, which is this recklessness, usually, or risk-taking behavior, and like sex, drugs, rock and roll, right? You know, they're driving, they get their driver's license at 16, and another risk behavior is speeding, things like gambling, things like sex, and then one other, we can go on and on and on, but another one is experimentation with alcohol and drugs that we're really, as a field, this is the area that we spend a lot of time around, really thinking about this nuance in this issue. We know developmentally that from research throughout the years that alcohol and drug use is a developmental phenomena. And we know this through a lot of research and theories that have been developed. One theory is the developmental substance use risk model. And this slide here with a lot of numbers, it's an older one, but I like to use it. It's from Monitoring the Future. And what it shows is that a bunch of percentages. You might be like, what's all those numbers about? But what I think it shows, and it continues to show as we see these trends happen nationally and annually around substance use, when we begin to monitor use and just regular prevalence that asks in your life, have you used alcohol, have you used any illicit drug, have you used marijuana, have you used tobacco, you see adolescents from early on from the age of 8th grade to 10th grade to 12th grade are reporting yes. There's not zero percentages here, and you know, there's about 8th grade, you'll see about 20%, you see it increase the prevalence as they enter into 10th grade up to about a third, to about 40%, and by 12th grade, always more than half are reporting that they are using alcohol and drugs. So we know that use is very common. We know that more and more issues around access, issues around availability in our state are becoming nuances for us as providers. We do know we have Prop 64 that's being implemented in January, right, recreational marijuana. And so the whole issue around how youth are forming, you know, cognitive, social, emotional, and biological changes that are occurring, they're interacting with the environment and what's happening in the environment of what is the norm, what do they see in their homes, what do they see in their communities. And so it's this interesting tension that's happening during development where they're developing attitudes and values around drugs and alcohol. And so with drugs and alcohol being readily available in our society, with a lot of pro-social attitudes towards the use and consumption of alcohol and drugs like tobacco, alcohol, and marijuana, this just reinforces this risk-taking behavior phenomena of it just being natural tendency, right? They don't see a problem with it. It's widely available. So this reinforces this theory that it's part of normal adolescent development where there are, during these significant changes, youth are trying to figure out where they fit in to their contextual world, right? And so substance use experimentation has been and still is a normal part of this development period. Volumes of research show that, and decades of research have shown that youth use substances, however, experimentally, but with varying degrees of risk. So we do see here that there is, you know, not all adolescents, you know, it's not, this isn't 100%, right? So we need to be mindful of that, but it's common, right? So there are most youth or a majority of youth are experimenting, and so the use patterns will fluctuate, and they're very diverse. We cannot treat all adolescents and all youth as a one-size-fit-all model, right? There's going to be nuances, and what these nuances are these risk factors. There's going to be protective factors. So what are those? Those are important to understand as providers who do prevention and who do treatment. This shows you this is a continuum, and this is a substance use disorder risk trajectory. We do know from research that one use or one experimentation doesn't mean they have an addiction, doesn't mean they have a disorder. But we do know from research is it means that they now are at risk for a substance use disorder trajectory. And largely the risk indicator is use, right? How much they're using, what they're using, how long they're using, because it's interacting with their social cultural environment, which will reinforce, but it's also interacting and it's affecting the brain, right? So we're going to talk about that. There's low risk, there's moderate, and then there's high risk. And this is important to understand. Low risk, these are your youth who are curious, right? They try substances, but they do not continue in frequent patterns. These are youth who would greatly benefit from prevention efforts and continue to expose them to prevention. I think at all levels. I do think primary prevention should really begin earlier than high school. primary prevention research support should be beginning early on in middle school, junior high, right, as they're going through these significant emotional, social, cognitive changes that are occurring. And they should continue, I think, throughout high school prevention, but we need to open up and expand our areas of prevention. We primarily do primary prevention, which is getting young people to never use alcohol and drugs. But we know we're fighting against the big current, right, this developmental risk trajectory that we know from research is taking place. So how do we shift and adapt prevention to address and effectively these varying levels of risk? Well, that's these moderate risk youth that will really benefit from secondary prevention, right? It's getting youth are early users, they're adopters, and they are increasing to use. Their patterns don't just stop, they're not just one and done, but their use is being continued by risk factors, right? And they would greatly benefit from interventions around how to address risk, how to bring up their risk, and how to understand their risk, what are the risk factors. That's really leading to what we call purpose. Why are they using? Their use is beyond experimental. So there's a triangle here at the bottom right hand of the page, right, where we know developmentally it's going to be experimental and it's going to be curious. These are like probably the low risk. But then substance use is going to do something for them, usually with their peer groups, usually there's a lot of theories that we're going to cover. It might be related to helping them fit into their culture and their context. It might be helping them be a relief from something in their culture or their context, but it's serving a purpose. And then over time, with continued use, we do know it gets more intense and more severe, and then that is that clinical trajectory that we see occur where treatment interventions are more appropriate than just risk reduction. And then there's the high risk, which are these youth that we just talked about at the tail end, where they are continuing to use and their use is becoming more frequent, more daily. These are daily or monthly patterns, not just episodic social patterns, and they serve a purpose, right, emotional, cognitive, or other behavioral issues. So it's important to understand and recognize that there's different risk levels, and for us to really be aware of what are the risk what are the risk factors, and what are the protective factors. This is important as we talk about later of what medical necessity means now in California for youth. We should be mindful of this notion of being at risk versus just having a substance use disorder. And in our field, we've been either they don't have any substance use, primary prevention, or they have a disorder. As a field, we haven't been exposed to, or we haven't worked within these models of this middle ground of what it means to be at risk and what risk looks like. We know that substance use disorders and the risk for substance use disorder trajectory is very complex. There are several individual differences. We have models and theories around what puts youth at risk that I think is important to understand. But again, there is nuances, and really what the goal is for the field to move towards patient-centered care, right? Really spending time and focusing in on individual differences, just like it's being done in healthcare and being defined by the Institute of Medicine around what quality care means. It really means spending time and understanding individual differences. And when we begin to engage in risk reduction interventions, these are one-on-one, right? We're not doing treatment and we're not doing group, where all youth are put into a setting and they're treated homogenously, right, that they're all the same. No, we're taking a step back and we're saying, okay, well, this youth is at risk. Well, why are they at risk? What are their risk factors that we can spend time on during an intervention to really highlight and understand individually and personally, right? So there's a benefit around doing risk reduction because of that. So there's several integrated risk factors. We do know that they're themed into these major areas around a biopsychosocial model, if you will. We know that there's biological factors. We really, as a field, have honed in on brain and brain mechanisms that we'll cover, but then there's also the whole nature-nurture, right, individual differences, and then there's environmental that are and then there's behavioral. And the brain and the behavior are going to go hand in hand, because we do know that the brain, you know, directs how we feel. The brain directs how we think, these emotional and cognitive kind of processes that are developing. And we do know how we think and how we feel directly affect what? Our behavior, right? So that's why the behavior is directly under the brain, but we do know that it's kind of sandwiched, if you will, by biological and environmental factors, these risk and protective factors that we need to understand as a field. So that's what this model is showing you there. Research has shown over the years that there are these what we call pathways, right? There's a lot of research that comes out of the field of psychology, clinical psychology and social psychology and health psychology in particular, and developmental. There's a lot of different fields in psychology, but these are the ones that really look at the nuances around development and understanding what we call trajectories or what we call predictive pathways towards the substance use disorder risk behavior. So if you see here, there's a lot going on, but this is a pathway model. So we look at, we tend to base this on confirmatory factor analysis around putting a bunch of factors, right, what we call constructs, are these important predictors, into modeling that will then spit out, is it a negative predictor, is it a positive predictor, is it a protective, or is it a risk factor, to really allow us to understand how to direct our prevention efforts, how to direct our treatment efforts, what should we be focusing in on. Well, what does the research say in terms of risk? So here, we know environment and we know individual. These are these orange big ones. But pathways, the pathways under environment have shown us that they fall into largely three areas, right? These socialization pathways, if you will. Neighborhood, family, and school work. These are these contexts in which youth are in, right? They spend the most of their time. We can add here, and there's another pathway model I'm going to spend next, which is the dysregulation pathway, which are systems, right? So foster care youth that really spend time in that system, that could be added here, that we need to be mindful of as well. But this is the main kind of pathway that is used. So I put the green box here that many longitudinal studies with high risk or at-risk youth support what we call a dysregulation pathway. So we'll get to that. But this pathway here is a kind of normal, kind of adolescent trajectory that has a family environment that are not in the system, if you will. So neighborhood, family, school, work, if you will, but it's mainly school. The work would be more for the older age, young adult youth in particular. So neighborhood risk factors here would be like high access, we talked about earlier, high availability, right, advertisements, saturated communities with liquor stores and stores where smoke shops and, right, these are going to create positive social norms around substance use in communities and in settings. And then there's school or family. There's particular risk factors and a lot of research around what is it about the family context that puts youth at risk for substance use trajectories. And one big area is parental use, seeing substance use in the home. Another one is trauma. This could be exposed to several factors like single families, you know, one parent, incarcerated parent. It could be poverty. It could be transitions. It could be loss of a loved one. It could be seen early, like gang involvement in families. These types of things, trauma can be broadly defined, or it could also be abuse and neglect, and being exposed to physical, emotional, and sexual abuse and neglect. Then there's a whole research around that. And then low affection, it could be variety of parenting styles and attachment theory that has been studied in this area, and then also parenting styles around high conflict or authoritative, right? Too much structure and not enough affection, and really this imbalance. So low affection, high conflict. And then the school environment, a variety of risk factors there where there might be learning disabilities, like an educational kind of a special need, like an IEP or EAP, low attachment to the school. They're not really liking the school. They have conflict with teachers, administrators. There's poor performance. They're not doing well in school. And then there's problematic grit, another kind of area of study, right? Youth aren't motivated. They're not futuristic. And all of these three kind of environmental factors, particularly, they highly correlate, right? So you're going to see a lot of correlation between these three areas, and being not attached to the family, or issues. You'll see issues in school, or you'll see high neighborhood issues. You'll see it impact school. But these directly or negatively, these are the negative arrows here, will negatively affect their social networks and their participation with what we call like deviant peer groups, where they'll engage with other youth who use alcohol and drugs. They'll have unstable attachment as well with their peers. They'll seek attachment because they're not finding it in the home, with interpersonal relationships like being involved in gangs or cliques, or with early sexual risk behaviors with youth. If they don't have attachment or affection at home, they seek it elsewhere. So this nuance is there with social networks. So having poor family environments or negative and dysfunction and conflict are going to lead them to have attachments in their social network that are higher and more pronounced and positive than their family, but then there's some risk factors that are happening in the social network that are important to consider. Then these negatively affect their individual factors. These are things like their emotional disturbances. This could be low self-esteem. This could be unstable identities, poor self-control, and then skewed values and beliefs, right? How do they view alcohol and drug use? It might be leading to purpose for them, particularly if they see it in the home, or if they see it in their social networks that are meaningful to them because the home environment is not real meaningful. They see it in their neighborhood as positive. So they're going to have skewed values and beliefs, or what we call distorted risk perceptions. There's a whole area of research around that. And that will then positively, these positive kind of boxes here, positively lead to a risk for substance use behaviors and trajectories for disorders. Many longitudinal studies, though, however, like I said, really, when you deal with substance-using youth, really push us to understand and view this dysregulation pathway. And a lot of the work stems out of the ACEs study. Many of you might be familiar with ACEs. ACEs was a study conducted by the Centers for Disease Control, the CDC, and it stands for Adverse, the bottom here, Adverse Childhood Experiences Study. It was based on a big sample, over 17,000 youth who were recruited, and they were followed over time, a longitudinal, over a period of 10 years or more. And they took youth and they identified they tracked those youth who had been exposed to adverse events, enduring stressors, and these could be a variety of things. They're on the left-hand side. Maltreatment, neglect, like trauma generally, family dysfunction, domestic violence in the home, substance use disorders in the family or incarceration, legal issues in the family, foster care system involvement, and then gang involvement, violence, crime. And so these serve as risk factors that will then set the stage for general risk, emotional and cognitive and behavioral disorders, like symptoms, like conduct disorder, things like poor attachment patterns, things like personality disorders, low self-esteem. These are what we call disorders or dysregulation, And the scan of the brain on top shows that there is biological changes that are occurring with exposure to adverse events early on. Earlier exposure to these types of issues are already, research shows, changing the brain, right? It impacts the developing brain. You see on the left-hand side is a scan of a normal kind of brain. This is a 3-year-old child, and on the it's fully full and healthy. On the right-hand side, you see a brain that's exposed to extreme neglect. You see that there's changes physiological and structurally that are occurring. And so enduring stressors, research has shown, impacts the developing brain, and it increases risk for this trajectory, for this having poor emotional and cognitive early on dysregulation, or inability to control impulses early on, or inability to control mood. Remember, I talked about that developing processes and inability to self-regulate their behaviors. And so the introduction, though, that puts them at risk for things like substance use. So you'll see it's not substance use affecting those issues, but it's these early issues that are increasing their risk for engaging in substance use. So this is an important theory to also understand, because it's not just normal development, but it's this exposure to pre-existing trauma or early adverse events that you see here in the pyramid that will then lead them to have social, emotional, cognitive impairment, trouble in school, grade failure, lack of focus, and other behavioral problems that will then increase their risk for the adoption of these risk behaviors. That include substance use, early sexual risk behaviors, early violence like bullying and aggression and anger, that will then increase risk for disorder and disability and system involvement, and then increase morbidity and mortality. So this is another risk trajectory model to really understand with youth, and not just it's part of normal development and you just use substances because they're fun and you're curious. Well, no, these are youth who have different risk factors, where a lot of the use is going to be, again, this purpose, right? And there's these different risk level diverse patterns, so it's really nuancing and being able to tease these things out, which is important. A note on parental use. There's a lot of research on the parental kind of pathway and risk for youth. There's a lot of parent and a lot of the research, it gets dropped, because if you look at my model here, the most pronounced focus has become peers, right? But because they have early dysfunction in parents, so they'll be like, well, now we need to hone in on our efforts on the peers. And a lot of that gets kind of introduced in treatment, if you will, where it's like, well, let's talk about people, places, and things. Let's talk about your friends. Let's help you make different friend groups. And that's important. I think that shouldn't be lost. But we need to include the family in the service system, in the efforts early on and throughout the trajectory with youth, because of the strong research that shows that they are one of the impediments and the social drivers that will continue to drive it, that will, regardless of peers, they will continue to be the behind-the-scenes risk factor that needs to be addressed, I think, within the clinical context and in interventions as well as in treatment models. There's a lot of work on parental use and early exposure, and it doesn't necessarily even mean parental substance abuse history. It just means parental use, right, in our homes. And if you think about context, Prop 64 is just an example of marijuana being voted in by the people, right, by families, by parents, by, the public. And if you begin to think about, alcohol and tobacco, that is in the homes, that is in communities, that is in refrigerators, that is at parties at homes, right? So this notion of parental use here, research has shown not just parental addiction, but just general use in their homes. It's important to bring education to the families around this risk factor and really begin to understand if you are going to have it in your home, you need to also communicate and know that your youth are watching you, and you need to have a healthy communication at home around the risks and, this notion of, because this gets disconnected. This research shows that early exposure to alcohol use in the home right, not just problem, is a really significant risk factor for the age of onset of drinking. So what this shows here is that those youth that have a positive parental history of seeing alcohol in the home, the green bar, this is showing that youth are drinking at earlier ages. They're more likely to than those youth that are not exposed, the blue bar, at home. They're not exposed to alcohol, not alcohol problems, just alcohol drinking. They're less likely to drink alcohol earlier on, right? So this is an important nuance for our prevention efforts and as well as the inclusion of family, not just around like, you need to support my kid, you know, help him. Well, it's like, well, what's happening in your home with, do you have alcohol in your home? Do you have marijuana in your home, in your family events? This is important. They need to be included in this effort. Major risk factor, another major risk factor that we're going to really spend a lot of time on in these next couple of slides, and this is important for you to be mindful of as workforce with youth around prevention and treatment, is really including this information around the risk of substance use disorders that we're going to be covering moving forward on the next couple of slides in your interactions with youth, right, around this notion of the brain and the developing brain and the impact it is having on them for their risk trajectories. Adolescents are not receptive towards us telling them, that's bad for you, you shouldn't do it. They won't listen. But they're receptive to, wow, I know you're going to do that, and I know it feels good, but you're putting yourself at risk for some issues. Have you thought about the risk that's happening with your developing brain and how that might lead you towards a trajectory of you not being able to stop? Right now, you can stop whenever you want, but because just like a diabetic or somebody with obesity, if they're not going to regulate and control their exercise and their diet, it's going to lead to problems down the road. Same thing with alcohol and drugs. If you're not going to control and regulate your intake of alcohol and drugs and be mindful of the changes that are occurring physiologically, that's going to have repercussions down the road. Not right now. You can eat anything you want right now. You don't have to exercise right now. You can do drugs right now, but it's going to have repercussions down the road because of the physiological and neurological changes that are occurring. This information is important for youth to understand. So another major risk factor is the drug itself and how it affects the central nervous system. So this is the drug as well as the different effects, like what actions they have on the central nervous system, right, the brain and body, the potency and the purity, the quality, the type of substance that the adolescent is using. Not all marijuana is the same, not all opioids are the same, or heroin, not all methamphetamine is the same. There's different quality and potency and purity, right, and particularly with synthetic, and the route. So these kinds of nuanced information, although we take it for granted that we know about it and we're going to be telling them it's bad, but they need to know about it earlier on within the risk discussions, in addition to how it interacts and reinforces the individual and the environmental kind of factors. So, okay, so what are youth using? We do know that youth use, you know, the epidemiology of substance use among youth. We do know that youth are using anything they can get their hands on, usually, within their social cultural surroundings. So what's accessible, what's most available is what youth are using, right? So if you see this slide, it's alcohol, it's marijuana, it's cigarettes, and it's your prescription and over-the-counter meds and drugs, it's hallucinogens, it's inhalants, it's ecstasy, MDMA. It's these things that are readily available, right? You see use increases over time, right? This is the 8th, 12th in college. So we do know that, you know, the younger age youth are going to be using a lot more things that are less invasive, like the cigarettes and the, you know, alcohol earlier, and then have a tendency as they get older to begin to use some of the other more illicit drugs like heroin and the cocaine and the meth. They don't usually start with heroin, cocaine, and meth. They usually start with some of the earlier, more accessible substances. But we do know that there's a tendency for youth to use more than one substance at one time, right, what we call polysubstance use. There's significant brain effects that are happening with different types of drugs, right? So there's different risk associated with different types of substances. They are going to bind to different brain receptors differently. And so this chart shows us that drugs and alcohol substances are classified as either depressants, stimulants, or hallucinogens, and they affect the central nervous system differently. What do depressants do, right? Depressants slow down the central nervous system. What do stimulants do? Stimulants speed up the central nervous system. And what do hallucinogens do? They trip up, right? They trip up the central nervous system, right? They lead to distorted perceptions of reality, visually, auditory, smell. And if you look at marijuana, this is important for you to understand, at low doses, it can serve as a depressant and slow down the central nervous system, but in high doses, it can serve as a hallucinogen, right? So we're seeing more and more with the different potency and types of THC, more of them are hallucinogen. They have hallucinogen-like properties with higher levels of THC. So the effects we're seeing are things like hallucinations, things like psychosis, right? Because we don't have the THC of the 60s anymore, and low doses of THC, which serve as a depressant. So it's important to understand that there's these nuances and to be educated and mindful of the properties and effects of substances that youth use, like inhalants. What do those do to the brain? Like MDMA and ecstasy. Taking that one time can really trip up and really affect the central nervous system in very dangerous ways, one time or repeated times, versus things like alcohol, binge drinking, right, and the alcohol poisoning that we see among young adults. It's important for them to understand the amount of alcohol and how it affects their central nervous system versus drinking is just bad and don't do it, right? So they'll be more receptive to that. Polysubstance use, this is a very significant risk factor that we have learned from the field that heightens their susceptibility towards substance use disorder risk trajectories. It's the norm among youth, but it's also a high risk factor. Why is it a high risk factor? Because they're using substances that have psychoactive properties that are either going to speed up the brain and central nervous system, they're going to and slow it down at the same time, or they're going to slow it down and trip it up at the same time. So as they ingest substances with a variety of effects, they're directly impacting the brain and body in ways that our brain and body is not naturally made to endure. And you need to understand this. And this has significant effects on the brain and the changing state of the brain that is occurring with polysubstance use. So let's look at the brain. Let's spend some time talking about the brain. Inside the adolescent brain, NIH, the National Institute of Health, and specifically three different places under NIH that are important places to get information. We have the National Institute of Mental Health, NIMH. We have the National Institute of Alcohol Abuse and Alcoholism, NIAAA, and we have the National Institute of Drug Abuse, right? So these three agencies at the national level are important. They all are doing a lot of work right now and research on the developing brain. There's a large study called the ABCB study. It's a longitudinal study, and it's really spending a lot of effort and resources on the changing brain, right? We talked about there's significant growth and change physiologically, and that's happening as the brain is maturing. And so this huge study across these national entities, they are implementing brain imaging at 10, 11, 12, 13, 14, 15, throughout this age trajectory, and they're looking at the nuanced impact of just what experimental drug use looks like versus the continued use, this mild and moderate risk kind of levels, and the higher risk levels, and the nuances of what early trauma looks like with substance use, and what the brain looks like. We don't have that research right now for me to begin to show you, but it is coming out in the next couple of years, which is really exciting for our field. So I kind of just want to put that on your radars. But we do know that substance from the brain imaging work and the brain studies we have had over the last 2 decades or so is that addiction is a brain disease. Substance use disorders are brain issues, right? And substance use disorders from this brain work and longitudinal research have been characterized as adolescent onset disorders. What does that mean? They mean it starts young, because we do know that alcohol and drug use start early, right? So it's not necessarily a disorder from the get-go, but they are at risk for the trajectory. That's why they're called onset. That's when they begin and their risk trajectory kicks in, and there's a lot of risk different factors, right, that we just covered to keep in mind. But that's why they're known as an at-risk population. There's well-supported scientific evidence that shows that adolescence is a critical at-risk period, like we talked about earlier, for substance use. And all addictive drugs, right, that have psychoactive chemicals, right, that we just covered, that are playing on the CNS, the central nervous system, like alcohol, like marijuana. And we're going to spend a little bit of time talking about marijuana, because adolescents or young people don't think marijuana is a drug. They think it's a medicine, right? They don't think it has psychoactive addictive properties. They think it's safe, right? And so this is very important for us to be mindful of, and how do we begin to change our practices and the information we're conveying to them to ensure that they understand it's a drug and that they are at risk, right? They have especially harmful effects on the adolescent brain, which is still undergoing significant development. So if you haven't received or downloaded the Surgeon General's report on alcohol and drugs, it was published in January. I strongly encourage all of you to get that resource. It's available on the web, and it has a lot of information on the developing brain that is integrated into the nuances and understanding around addiction as an adolescent onset that is important for you to use to better improve your as a resource to use with youth and families. So let's spend some time talking about the importance of the brain and the risk developmental trajectories. There is a whole line of work that started in this area of brain imaging in the early 90s, really around learning how people get addicted to drugs, a lot around this sex and pornography and these sex addictions, around eating disorders and disordered eating, and then drinking and smoking. And a lot back then, there were scientists were reported here in Time magazine, were discovering the chemical secret, right? Back then, we had a lot of social behavioral models, right, where it was drug use was a behavioral phenomena, it was a habit, it was learned. Drug use was just simply brought reward, right? There was like early animal studies where they would, you'd give them drugs, they would want it because it produced pleasure, it produced a high. But we didn't have a lot of research on what was the chemical processes that were happening in the brain that led to the point where they can it was no longer pleasurable, right? It no longer brought reward. It was this point where they continued to use to seek reward, this impulsive, continual pattern of seeking and using, right, where they couldn't stop it. Right, on their own. It wasn't like, just stop now. Oh, well, I can't. What happened in the brain, right, that clicked to this point of addiction, right, this chemical imbalance? And so there was a lot of imaging, a lot of work that was being done at the time. And there was, we've had since then decades of research in the early 90s. And in 97, during this decade in the early 90s, Ellen Leshner, who was the former director of NIDA, the National Institute of Drug Abuse, came out with this article that was stellar. It changed the field. It was pioneering, where the title read, "Addiction is a Brain Disease, and it Matters," right? It really shifted the paradigm around addiction is a social kind of behavioral phenomena where we, just try harder and participate in NA and AA and give up our power to a higher power, and we'll be fine, right? Versus it's a disease of the brain and it might need some medicine, versus it's a disease of the brain and it might need more long-term care, versus it's a disease of the brain where it might need aftercare and recovery support beyond NA or AA, which is important because it's a community support group. We know that other chronic illnesses like diabetes and hypertension and eating disorders, there's value in community support groups, social support groups, but we all know that they have nuanced care that is long-term. We know they have nuanced care that there's aftercare models. We know they have nuanced care where there might be some medication available around that. We know there's nuanced care where they have case management and a whole variety of other kind of care, right? At the time, our treatment system was a very acute-based model, right? It was short-lived treatment, and they were one and done. They were supposed to discharge from maybe a 3 months worth of treatment, and they were supposed to be squeaky clean, never use alcohol and drugs again, and never relapse. But we know that that was not occurring, right? We saw through continued research that we added to this notion of being a brain disease as well as a chronic and relapsing condition, where Tom McClellan came up with some stellar research around viewing it and shifting it being just this acute brain issue to a health issue, right? Just like diabetes, just like hypertension, just like other mental health issues, where it's a behavioral health issue that deserves to be treated like a health issue versus a stigmatized, shaming issue that should just be isolated in the community in these hubs that are quick fixes. So this was really instrumental. My slides need to show. Let me share my screen. I'm going to do something here because I have some things that need to come up. Can you see the slides?
Yeah. Yes.
Okay, good. So I'm going to come here, and I'm going to, can you see the slides?
Yes. Yes.
Okay, good. So digging deeper into the addiction process via the brain. So research supports, if you look on the right-hand side, and hopefully you see a brain that's moving and pumping, and this just really shows the nuances we've been able to learn from brain imaging studies where the brain, as it's developing or as it's maturing from the back, right, the end of the brain, all the way to the front. It's pruning, and it's back to front, and the last part of the brain to fully develop until the age of 24 is this front part, which is the prefrontal cortex, right? So here in this blue box, you see, because of the developing process, the earlier parts of development that have been matured and developed are these earlier processes that these back parts of the brain are controlling, right? Occipital lobes and the vision and motor and coordination and sensations. However, the later parts that are fully maturing are this prefrontal cortex pieces around the amygdala that controls mood, the hippocampus that controls cognitive processes and memory, and then this prefrontal cortex or this VTA system that controls motivation, and then executive functioning like judgment and impulse control. So these major processes of the brain that are maturing during this period, right, are interrupted or disrupted by substance use. We know substance use is like we said earlier, when ingested, they affect the central nervous system. They also affect brains that are being developed. What parts of the brain? So research has shown us that there are a couple of areas that are heavily affected by the developing brain by substance use, right? This is the prefrontal cortex here. In blue, it's the PFC, and it's in charge with inhibitory control or decision-making and self-regulation. Also, the nucleus accumbens here, which is the OFC and the SCC, as well as the limbic system, which is the amygdala, the purple, and the hippocampus, right? And within these centers, which is these areas, the limbic system in particular is probably the most important in the addiction process because it controls the green and the red boxes, right? It controls motivation and drive, and it controls pleasure or reward, and salience. What does salience mean? It means imprinting. It means the brain remembers, right? It begins to become conditioned, right? So alcohol drug use, once it's used, it creates salience. It means it remembers that that chemical brought a feeling of reward, and then there's a motivation or a desire to seek that out again, just like food, right? And it begins these environmental cues, just like eating, salience happens. So when we see like a billboard that shows a hamburger or a shake, our brain is going to be conditioned to be like, I want that, because it leads to reward, and and particularly when the brain's exhausted, if it's hungry or it's in these states of like, if there's, for substance use, if there's stress, right, that salience is going to then be associated, or the use is going to be associated or learned to be associated with bringing, feeling better about oneself. So there are these interesting processes that are occurring that I think are important to be mindful of. So as this pathway, called the limbic pathway, or the reward center of the brain, it activates the reward pathway. Addictive drugs activate this pathway. So all brain imaging has showed us that all substances, it could be marijuana is not on here, but as well as marijuana, activate this pathway. And so it basically interrupts or disrupts the normal functioning of this pathway, right? So studies support that because of this, we begin to see that there's major interruptions, if you will, that are occurring in these centers of the brain. And developmentally, we know that in addition to reward and motivation, there's these other important elements that we talked about earlier that are developing. Things with like decision-making and judgment and thinking skills. Things with controlling their mood and impulses and their emotion. And things like controlling their behavior, right, their risk-taking. And so we know that on the right-hand side of this slide here, that these are pictures of the neuroimaging pictures of somebody with an addicted brain, right? They've been using substances over time, and there are changes that are occurring not only physiologically. This shows physiological change where there's less red and less yellow. On the left-hand side, this is a healthy brain. You see a lot of red and you see a lot of yellow. This means that there's a lot of, in the left-hand side here, dopamine, DA is dopamine, and metabolic, right, brain, blood flow to these areas of the brain, and receptor availability, right? This is like the normal processes that our brain functions. Like, so if we eat a cheeseburger and drink a shake, then it releases dopamine into our synaptic cleft, and then we feel good for a little while, and then that dopamine gets recycled back in, right? It gets reuptook by receptors back into our brain. But when drugs and alcohol are used, it releases a lot of dopamine, more than the normal cheeseburger or more than the normal hugs and kisses, right? And so that amount of dopamine in the brain is going to negatively impair receptor function, and it's going to actually lead to blocking, right? So drugs mimic certain receptor shapes, and they'll attach to them, and they'll be in that reservoir for not just, a minute or 2 minutes after we eat or after somebody has sex and that feel-good feeling goes away. Drugs and alcohol stay in the system for like 8 to 12 hours, sometimes 24 hours. So staying in the brain for that amount of time is changing the normal processes of it, being able to get reuptook into the system. And so the receptor availability crashes, right? They become cave-in. So I say that because there's actual physical and anatomical structural changes that are also occurring in the brain as well that are impairing these developing processes. Okay. So what does substance use medical necessity entail or mean for youth in California? There are two areas that are important to consider, but before we talk about those, we didn't have medical necessity for substance use field. I don't know in Shasta County if that was the case, but in LA County and several other counties, this whole area of medical necessity is new. And the way we dealt with substance use for our field was, like we talked about earlier, we either did prevention or we do treatment. We did nothing in between. Business as usual, we usually would receive referrals or mandates from a system of some sort, usually the school or legal or concerned parents, and we would admit them into our treatment program. And we would probably use an in-home assessment of some sort, or an addiction severity index, which is a research tool that California adopted years ago. It's not a clinical tool. And so this was business as usual. What I'm going to do now is I'm going to stop sharing and I'm going to come back to this slide here. Can you guys see my slides?
Yes.
Okay, good. And so what we have now is we have, was there a question? No. What we have now is we have, I'm going to mute. What we have now is we have medical necessity in California. And it's part of the drug Medi-Cal benefit, but in California it's the EPSDT benefit. And EPSDT stands for Early Periodic Screening, Diagnostic, and Treatment. It's a federal pediatric assurance that all states oversee, and it's under Medicare, Medicaid, and in California it's Medi-Cal. But EPSDT is a Medi-Cal benefit for youth under 21. So again, it's this definition that I talked about earlier, where it's 12 to 20, that goes beyond different county ages, right, who are enrolled in Medi-Cal. They can receive medically necessary and age-appropriate services, which includes a host of mental, medical, dental services for health conditions, but this also includes substance use disorder services. And the definition, medical necessity, they can receive these services under the Medi-Cal benefit in California, should they, and their expanded benefits, like aftercare, like case management, and they can continue to receive substance use services should they be eligible and meet medical necessity. And according to California, I don't know if Shasta County is participating in the waiver this year, but if they should, they participate and become a full benefit down the road. According to California, medical necessity is having at least one diagnosis of a substance use disorder, so being diagnosed with a SUD, or this notion of being at risk for developing a substance use disorder. And so this is new to the system of care. As we talked about earlier, traditionally identifying at risk has not been a standard practice of care for youth entering our system, right? They'd either receive prevention or they'd receive treatment, full clinical treatment. Decades and decades of research, as we talked about earlier, not just developmentally, but also from NIDA, the National Institute of Drug Abuse, as well as SAMHSA, the Substance Abuse Mental Health Service Administration, support including at-risk in the youth system of care, as youth would greatly benefit from risk reduction interventions. If you look at NIDA's principles of effective treatment for adolescents, they have 9 principles of effective treatment. The first five have to do with this notion of screening for risk. Amber, I see your question. I'll get to that. The first 5 have to do with screening for risk, and as well as implementing interventions, right? So I'm going to unmute you, Amber, because I had you on mute. Hi, Amber.
This is Diane. I was just going to say that we have opted into the drug Medi-Cal waiver, and we are participating in the regional model under with partnership that will be taking over responsibility for drug Medi-Cal for our There's 7 counties, I believe, of us that are involved.
Okay, good. So you are participating in that waiver. So what that means is, as a county, now, you know, you're nuanced with this expanded model of medical necessity, and it no longer just includes a disorder of having a substance use disorder, but it includes being at risk. So good. So what does that mean? We're going to cover that and how to better prepare for that. In the next, well, some of this webinar, and then in the next webinar specifically. But this has expanded our system of care, right? It addresses a major gap in our system. It's very promising. I'm really excited that Shasta County is participating in the waiver because it provides opportunity to try on and really include in our system of care appropriate services, right, that we haven't been including for years and years. And so this middle part is this new service area, right, of this at-risk. What do we do with at-risk youth, right? We don't give them primary prevention because they're using alcohol and drugs, because primary prevention, we do know, is getting kids to not use alcohol and drugs. And so our efforts are drug education, right? Working with community coalitions on environmental strategies, right? Working with schools and law enforcement around drug curriculum and education there, right? That's not interventions, right? That's not addressing risk. As another reason is primary prevention treats all youth as a one-size-fit-all model. It's like you're all going to get the same message, right? And as we talked about earlier, they need tailored risk messaging, right, in particular. Or we've had the right-hand side of the screen here where we do treatment, and we give them outpatient treatment or residential, and it works. You know, our system is using evidence-based practices there, but for other youth who aren't necessarily in need of clinical services, we tend to over-treat them, or we're over-medicalizing them, and that has repercussions for our system, right? That leads to early dropout, that leads to poor engagement, that leads to clinical outcomes we don't want because they're using alcohol and drugs still because they quite frankly didn't think they had a problem, and they probably don't have a clinical problem yet that is in need of treatment. So we've kind of been mistargeting our efforts there, right? So this middle ground of how do we begin to work with at-risk youth? And really it opens up opportunity for implementing risk reduction interventions, or what we call brief services. And under an EPSDT model, there is benefit. A lot of counties have had to shift and implement the at-risk under treatment services. I know LA County is doing that, where they're calling it 1.0 at-risk, right? Because under the ASAM model that we'll talk about, under California, the waiver, it doesn't cover 0.5 level service, which would be these risk services. So California's recognized that as a issue, and they then have told counties, or folks like me working with counties, to say, well, you're going to need to adapt your treatment system to then include intervention services, you know, innovatively. So, and how does that look? So how do we begin to do that as a county out there in Shasta? Well, you'd want to first begin to ensure that you have the capacity to identify these nuances, right? How do you understand risk versus diagnosis or disorder? And the starting place, and what's recommended by a lot of governing bodies, is screening. So the first step you should begin is not assessment. You should start with screening. And so routine screening with substance use as a health behavior, right? And we see this being done in healthcare and in mental health in general. Every year, youth should be screened for early issues, right, of diet, of exercise, dental screenings for tooth decay, cavities, you know, on and on and on and on. substance use should also be part of routine screening as a system of care. The EPSDT Medical Benefit cover, ensures and enforces this, national recommendations as a best practice by professional bodies, including NIH, including the American Academy of Pediatrics, including SAMHSA, and including California Society of Addiction Medicine. Why is screening important with youth versus jumping to assessment? It identifies or flags risk, right? It helps that warrant further assessment, which is the next step, and it's an important step. You can't stop at screening because our screening tools that I'll cover in a bit, we have 2 validated screening tools that we've used nationally as a field. They simply flag risk. They don't get into the nuances like I talked about earlier that are the important next step to understand individual level risk with all of these nuanced risk factors and protective factors that you can get from an assessment, right? So the screening is going to flag risk for further assessment, not treatment, assessment. You still want to nuance, do they have a diagnosis or are they simply at risk, right? So it's important to recognize this. And screening, the practice of screening is important for youth. Why? Because youth don't want to be in our system. They don't want to be in any system, frankly. And it helps us reduce stigma associated with substance use being a problem that needs assessment and that needs treatment right away. It helps us pre-screen. It helps us talk about screening substance use as a health issue that is screened routinely, right? So it reduces stigma and shame. It's like, well, we're screening substance use just like any other health behavior, just like, a sexual risk, just like wearing a seatbelt, just like how you eat, just like if you're exercising. Substance use is being seen as a health issue, and it's important to begin to talk to youth as such during screening, and it helps increase engagement in our system, in necessary services like assessment. Jumping from screening that flags risk it helps increase engagement of like, well, you flagged risk here. Do you mind if we just kind of ask a couple of other questions to kind of really get at what substance use means for you as a person? And they're, sure, why not? Versus they're referred, and the first thing we give them is an assessment, right? And to assess and diagnose. So it's an important engagement piece that I think our system has missed and hasn't done systematically. Principles of effective screening, we've learned from NIDA, the National Institute of Drug Abuse, and SAMHSA, and all these governing bodies, that screening should be brief, right? It should be efficient, it should be quick and easy to administer, and it should be compatible with your electronic health records. A lot of the systems of care in different counties are using electronic health records more and more, so you want to be able to use a tool that's compatible. The screening should also be comprehensive. Although it's brief and short, you're going to want to screen for important risk indicators that we know flag risk as a field, right? So it should screen for substances that youth use, right? These, notions of inhalants or tobacco. We should be screening for tobacco. Tobacco is a very important substance that, quite frankly, we ignore as a field. And we should be alcohol and other drugs that are commonly used by youth, like inhalants, like ecstasy, like prescription drugs. And it should be effective. It should be validated to identify risk among young people, right? And so the two screeners, there's a couple of others that you might use as an agency, but two that are being really pushed that address these effective screening practices is the CRAFT. The CRAFT is recognized and endorsed by the National American Academy of Pediatrics, by a lot of healthcare entities, by the National Quality Forum, and it has 6 items, and it is really brief, right? It's been validated for youth, and it screens for substance use broadly with the integration of risky behavior or issues that are important to kind of flag. And then the screening to brief intervention. It's called the S2BI. This is a newer screening tool that's been validated by NIDA, the NIH, and researchers out at Boston, at Children's Hospital in Boston. And this tool expands substance use screening beyond the craft to include other commonly used substances that adolescents or youth use. And it also distinguishes between these nuances of risk level that we talked about. Is it mild risk? Is it moderate risk? Is it like high risk? And it's 7 items. So let's look at these 2 screeners. And what systems are doing is they're coming up, at least in California and in other states, we see systems combine the 2 where they're using both of them, or they're coming up with their own tool that includes aspects of both of them, right? Not everything of the craft. They might pull out 2 items or 2 areas that are important, but they're definitely using all of the S2BI. And here's why. If you look at the craft on the left-hand side, Part A is the pre-screener, right? It has 3 questions, and it asks about consumption and if they've ever used. It doesn't ask about how much they're using, but it asks, have you ever used alcohol, marijuana, or anything to get high, right? It includes illegal drugs, just a drink or just a sniff or just a puff, yes or no. It doesn't categorize quantity or how much they're using, right? This notion of patterns of use. And remember, we talked about earlier, that's an important risk factor to consider. Not only have they used ever, but what is their pattern like? And if you look on the right-hand side, the S2BI does that. It asks, in the past year, how many times have you used these substances? This notion of quantity and consumption patterns is the risk factor that you want to flag, right? We know that adolescents use alcohol and drugs, probably, yeah, they'll use them, but what is their pattern? Is it less frequent or is it more frequent? And if they're using never or once or twice in the past year, that's low risk, right? We know that those low patterns, they probably used it, they were curious. However, if they're using monthly or weekly, we know that there's more moderate or severe risk there. There's a purpose there. There's a function because they're using more frequently. That's an important distinction that the craft on the left-hand side does not have. But it has Part B, which the screening to brief intervention does not have. The craft has these other important risk kind of flags that are important to consider during screening, which is, it's the acronym of CAR, right? It stands for have you ever ridden in a car? So these risky behaviors of drinking and driving or driving while intoxicated or interacting with friends who use, right, this peer use. That will flag that, as we talked about earlier. Number 2, do they ever use alcohol or drugs to relax? Or here's what the catcher is, to feel better about yourself or to fit in. Remember, this was an important risk factor early on that we talked about being a risk for that trajectory. So number 2 is an important indicator or flag. And number 3, this is one as well, right? This is going to flag that there's some psychological, maybe some trauma or maybe some dysfunction going on because it asks if they use alcohol or drugs when they're alone, right? So there might be, it's not social, they're not doing it to fit in, but it's taking on a different purpose, maybe self-medicating. You can get that with number 2, too, because it says relax, but number 2, relax, gets more at just general stressors, right? They have conflict with their family, maybe, or they're not doing well in school, or, you know, those types of things. Number 3 is this, it's a clinical indicator. That's something, there might be some trauma, they're using it because of self-esteem issues or some other stuff. Number 4 is cognitive impairment, right, with memory. If they're forgetting, right? So this is an important risk indicator as well. Do you ever forget things while you did while you were using alcohol or drugs? This gets at memory, but it also gets at their pattern of use, like blackouts. Have they forgot things, or have they ever had a blackout, like with binge drinking, or maybe they drink a lot and the next day they don't remember what happened? You want to kind of vet that during screening because that's an important kind of risk with adolescents. Number 5, this is an important one. Remember, we talked about family and peers. Do your family or friends ever tell you you should cut down your drinking or alcohol? So this whole notion of having family conflict, maybe getting in trouble. The number 6 is getting in trouble. Those, number 5 and 6 go hand in hand with the social kind of influences of the school and family, if you remember that risk trajectory model. So because of these questions, they flag risk that you're going to want to then flag here, and there's some risk, but you don't, if you just use the craft, you don't know how much risk because you don't know what they're using or how much they're using. If you use the S2BI, you're going to be able to understand patterns, better able to understand patterns. So I encourage counties to use a combination of two. Of the craft, maybe they don't use the whole craft, maybe they pull out, like LA County has rephrased some of these around, have you gotten into trouble, or you have issues with family or friends, or do you have mental health issues? So they haven't like specifically used the craft items, but they do use the S2BI in its entirety. And they don't use the craft because they're using the assessment that will vet and get at more of these issues. So it's up to, every county is different, but I strongly encourage the use of a combination of the two of them, and that's what the field encourages. So here, let's just look at using these screeners, using a case study, what that would look like. We have Jake. He's a 16-year-old boy who lives with his single mom. He's gone into trouble at school and at home on more than one occasion for smoking marijuana. He smokes marijuana almost daily to cope with these issues and to help him relax. He has issues with attention and learning. He reports histories of ADHD identified by a school counselor. He reports that he tends to hang out with older boys who supply him with alcohol, cigarettes, and marijuana. Jake doesn't care about school and only does the minimum amount of work to pass his classes. He has few friends at home and is rarely favored by his teachers. So I give you this background, but this is something that you can collect during a screener, and then how the screener would then look like it would be filled out. So he comes into your setting, or if in Shasta, if you use a centralized screening location, they would then use these screening questions, or if they come into your center, you would then use the screening questions first to then vet risk, right? So you would fill it out this way. No, he's never driven in a car. If you use the craft, yes, he indicated he uses to relax. No, he doesn't use while he's alone. Does he ever forget things? I don't think we got anything there. And then family or friends, yes, he gets, they say he should cut down, he got in trouble. And has he ever gotten in trouble? Yes. So the way you would score a craft by its validated tool as a measure is endorsing yes to 2 of these items would flag risk, would indicate risk, and further assessment. Now let's look at the S2BI on the right-hand side. We know from his patterns that he's using tobacco, alcohol, and marijuana. Those are the 3. And we know that he's using monthly and weekly, more so marijuana weekly than alcohol and tobacco are monthly. So based on this information, we would then understand risk flags. This is the top box, right? He has older peers, and that's where he gets his supply, so the peer influence. We know family issues and getting in trouble at school are there. We know he uses potentially for a mental health issue. He said relax and to help with his problems. We know there's some attention and learning stuff going on. And we know that he has consumption patterns in particular, and I underline that flags risk. The S2BI is based on consumption patterns. So this box here goes with the screening to brief intervention. So if you notice here, on the top, it's the response patterns, right, earlier. It's never once or twice, monthly or weekly. That's the response patterns of the S2BI. So he's doing the monthly or weekly. If you look at the appropriate response according to the screening tool, he should be referred for further assessment. Not treatment, assessment is the key here, right? To further vet, is he just at risk, or does he have a substance use disorder? So based on that, we would then go into understanding how substance use disorders are assessed for. And according to the new drug Medi-Cal waiver, and according to just our field, you need to use the DSM-5, right? We need to understand clinically if there is a substance use disorder. And let's just spend a little bit of time, and you're probably all familiar with the DSM, but if you're not, I just wanted to make sure we evaluate the history of how we came to the 5 and what the 5 is. So in the past, we had the 4. DSM-4, and we understood substance use as either clinically being substance abuse or substance dependence, right? DSM-4 had these two classification schemas for diagnosing substance use issues, right? And according to the diagnostic criteria, there was 11 there on your left-hand side, and these were criteria to then place them clinically into either abuse or dependence. And if you look at the first box, if they had one or more of these criteria, they would be classified as abuse. And if they had 3 or more of the criteria in the below box, they would be classified as having dependence. We no longer use substance abuse or dependence because we know that substance use issues are more complex than just being fit into these 2 boxes. It was very complex for providers to understand the nuances. Well, do they have abuse and not dependence? And then after dependence, from a treatment standpoint, what do they move towards? They go from dependence to what? Not having dependence. That's the goal. Remember the old model that we've had in the past, we go like one form of treatment for three months should help you with dependence or abuse, and you should shift away from abuse and dependence to not having it. So going from a diagnosis to a non-diagnosis is the key here, right? So it was very complex for our field to understand. There was a lot of research that was done by a group that spearheaded the DSM-5 changes that were occurring with substance use disorders. And now what we have is a DSM-5 of substance use moving away from abuse and dependence to being a substance use disorder that falls along a spectrum, just like you have with other mental health issues, right? A spectrum of what? Severity. Just like you have mild or more moderate or severe autism and along a spectrum, or like with depression, you have mild or moderate or severe along this, and it fluctuates along a spectrum. We have the same thing now for substance use as a health phenomena that fluctuates along severity. So now treatment models can breathe a little bit, right? You move from maybe having a severe disorder to more moderate or more mild, or at any one point in time they can move from mild to having a more moderate or severe, right? It's a spectrum, and it gives us opportunities to work along and embrace substance use disorders as a health issue that falls along a behavioral spectrum of risk and severity. So they now fall along one dimension, and you see at the bottom for a mild substance use disorder, it's having 2 to 3 of these criteria on the left-hand side. A moderate, they'd have 4 to 5, or severe, they'd have 5 or more. And there are some other changes from moving from abuse dependence to a disorder model. Research showed that legal, the criteria before that was used, had a poor fit in a kind of statistical modeling, and so it was dropped. It had a poor fit with what? Well, with these other items. So statistically, if you all know the DSM-5, what does the S stand for? The S stands for statistics, right? The Diagnostic Statistical Manual. And from a statistical standpoint, if you look at a statistical model that looks at how these items or these criteria go together, do they jive? Do they all correlate adequately together to then give us assurance that we are adequately diagnosing a substance use disorder with validity and reliability? Well, if you look at legal problems here, it had a poor fit with the other items. Across substances, they had 0.5, 0.3, 0.5, 0.6, right? That's not a good fit. A good fit is, according to statistics, the loading would have a 0.8 or above, 0.7 or above, right? Even hazardous here, 0.6, 0.7, that's one of those items that's like, that's questionable, but it has somewhat of a fit, and I think it stood because it picks up legal issues. And we added craving. You see here craving, so we replaced legal with craving, so we still have 11 criteria that are used. But craving fit very strongly, 0.9, 0.91, 0.91, 0.95. And if you look at the others, right, of the other symptoms such as tolerance and withdrawal, using larger amounts to get high. I'm going to jump here. The 11 symptom criteria really fall along 4 categories that map onto brain impairments, if you will, that are and social kind of issues that we want to really understand and nuance that we talked about earlier. So the first 4 criteria get at this inability to self-regulate or self-control. They cannot stop their use on their own. There's an impaired control. And craving fits into that area, right? That's an important indicator that got added that we didn't have as a field, right? That opened up the door to opportunity for medication-assisted treatment because we know craving is a neurological issue. We know that the brain, if you image the brain, it's a deep-seated, intense emotional drive that's the salience that I talked about earlier. Remember that salience imprinting and that reward and that desire or motivation? That's craving. That's that intense symptom to want and seek and have that the brain is doing. We didn't have that before, and it got added. But then it's these other areas of substance taking for longer periods than was intended, unsuccessful attempts to cut down or control use, and a lot of time spent obtaining or using or recovering from the effects of substances. This is impaired control. Then we have 3 criteria that fit under social impairment, right? These are important, where there's a failure to fulfill obligations or roles, right? Recreationally, in the home, at school, or in the community, and continued use despite these issues. So that's 5 through 7. Then there's these risk impact, right, 8 and 9, where it's use in these physically hazard conditions. That's kind of like drinking and like driving. That's the screener of the craft, right? Are you using while you're in a car? Or you like violence and having fights, right? Or continued use despite knowledge of problems, like health problems, right, that might be happening. Not social problems, but more risk to their health, their mental health and their physical health. And then the 10 and 11 are pharmacological impact, right? These are the tolerance and the withdrawal. It's important to use these criteria as well as when we talk to youth in the ASAM, if you're including DSM-5 questions in ASAM, which LA County is, I don't know if Shasta County is, but it's important to understand that there's these developmental considerations when you start asking about, you know, impaired control and social impairment, and really using language around their use, right, and their patterns. They don't have a long time, right, their age range. They might not have a long time with substances to get into these nuances of craving or unsuccessful attempts. They may have never tried to quit, right? So trying to be developmentally appropriate around how you ask these questions from a clinical standpoint is important to understand the nuances. So coming back up here, research showed that craving was added and legal was dropped. So now we have substance use disorders that falls along a spectrum and or a continuum, if you will. And what is the continuum based on? It's based on severity, right? And knowing that the number of symptoms can fluctuate at any time. This is important because this whole notion of at risk comes into play here. Because we know that if they don't meet these criteria here, if they don't meet these 11 criteria, that doesn't mean they're not going to meet them in the future, right? So this notion of continued screening or assessment, ongoing assessment, is important with substance use as well. We need to shift away from just an admission and a discharge, and medical necessity, I think, expands our practice around continuing to understand these risk factors that are occurring, because at any one point in time, and as I showed earlier around a spectrum of use, at any one point in time, their use can move into from just being experimental and low risk and moderate risk to more severe risk, and moderate and severe, enter into the stage of mild substance use disorder. So I wanted to point out the importance of continued assessment because of the spectrum use falls on in general. So mild, moderate, and severe, this also maps on to clinical severity now. So risk also is mild, moderate, and severe, and substance use disorders are also mild, moderate, and severe. And this is important with youth. When you start to begin to assess them for having a substance use disorder, you can be able to say, well, your use is mild. Your disorder, your diagnostic criteria that are posing issues reach mild threshold. That means there's improvement. That means that if you continue to use those, you can move up the spectrum and into more harmful territory where it's more moderate or severe. So we are going to work with you in terms of clinical strategies and skills to help you move from mild to self-manage, your issues. So that's another important kind of nuance to recognize with moving away from abuse dependence. It gives us fluidity in the field around our models and not treating youth as one-size-fits-all abuse or dependence. So let's review Jake. Does he have a substance use disorder criteria? It depends. His is really difficult. I think he presents a case that lends itself to difficulty in general because one area that you're gonna want to vet for these areas around, you're going to want to expand assessment that we didn't get from screening of how these areas are impacted, right? And so if he had 2 or 3 of these, he would meet mild substance use disorder. Should he have 1 of these, he would not meet substance use disorder. He would be at risk, right, for 1 of these. But you can't just stop at the at-risk. Let's say he doesn't meet criteria for having a substance use disorder. Let's say he meets 1 of these, and it's criteria 5 and 7, and this is just hypothetical. Maybe he's continuing to use despite interpersonal problems, because we do know his family. So number 6, maybe he meets that criteria, number 1, right? So we can use that. He doesn't have a substance use disorder yet, but he has that. So then what we would do is we would have to move on to a full assessment. Do you remember during screening, it flagged for risk for further assessment. The first assessment that's important to do is the DSM-5. We need to know if he meets criteria for a substance use disorder. He did not, let's say. We would then, the next step, we wouldn't stop there. We would still need to vet his other risk areas and explore them. We can do that through the ASAM assessment. Or through, according to the Medi-Cal waiver, you would need to use ASAM and DSM for medical necessity. So in addition to DSM-5, for further, you would need a comprehensive assessment to determine medical necessity, right? So he doesn't have a DSM-5, but that still doesn't say he doesn't meet medical necessity. He's still at risk, but what of these other criteria are important to understand? So we know youth come with a variety of different multidimensional issues: mental health, family, peers, legal, limited, pro-social, right, support. So after DSM-5, you're going to want to vet his other multidisciplinary or multidimensional areas. So you use, according to the ODS new waiver, you would use ASAM criteria or an ASAM structured assessment. And it's a tool that really allows flexibility for you as a clinical provider, as a counselor, to use your judgment, right? And it also allows for a lot of open-ended exploration around these critical 6 dimensions that are supported by research to be essential for us to understand risk and towards trajectories around disorders and full-blown disorders. So you can use them to vet not only if somebody has a disorder, say he met criteria, you would continue to use the ASAM to then really understand the nuances of his clinical disorder and what's going on with it in terms of these 6 dimensions. How, does he have withdrawal tolerance, and vet his past experience with that? Does he have any medical health conditions that might be interplaying with his disorder, like chronic pain or maybe got in an accident, or maybe his substance use isn't related to his health issues, but we do know it might be exacerbating any potential underlying health issues that the person might have. Do they have any emotional, behavioral, or cognitive complications? We do know from developmental kind of trajectories and the developing brain that you're going to see a lot of red flags here with youth in general, because of the constant emotional changes that are occurring, identity formation, cognitive issues around self-esteem, right? It's important to understand red flags versus full-blown mental health clinical disorders, and really using judgment there and what's occurring. And then this whole area around motivation, area 4, readiness to change. This is an important piece of the assessment that I think we haven't had in prior assessments that allow us opportunity to what? Meet the youth where they're at, stages of change. We're going to talk about that next time, and really using motivational interviewing during the assessment, and the importance of using motivational interviewing and strategies during the assessment, because we know youth have problems engaging in treatment or even in an assessment. We know the screener can help and can break down those barriers that we're already talking about, alcohol and drugs, but also they're going to continue to resist giving up substances, right? And you all know this in your experience with that. So readiness to change and vetting, exploring what their motivation is and where they're at in terms of change. And then number 5 is the peer aspect, or their social aspects, right? Like the continued problem potential. Do they have peers who use? Do they have any legal issues? Are they continuing to use despite, right, these notions of continuing to use and what it's doing for them? And then recovery environment, their family environment, their school environment, their friends, again, relationships, you vet that more there. And just like DSM-5, their severity along these dimensions is going to be either mild, none, mild, moderate, or severe. It uses severity, and it uses, like, how much are they impaired across these dimensions. So you would ask questions, and I think you're all using, if you have an ASAM tool that's already been developed, or you're using the state one, or if you're already developed one in Shasta County, I don't know what your process has been yet, but you're going to then take that information, and you're going to, as a provider and as a counselor, you're going to use your judgment clinically to rate them across severity and how much impairment they are showing across these 6 dimensions. You're going to use a lot of open-ended exploration of where they're at, individualize their risk there. And let's say they have, they're going to have mild across the board, dimension 5, dimension 6, mild and mild. We know from Jake across that area, but we don't know maybe some of these areas we're going to have to vet more fully through an assessment that you can use. And based on that information, you would then determine what their risk would look like. And depending on if you're going to have an in-home tool that going to have risk indicators, or you're just going to use the information that was collected during the ASAM. It is strongly recommended that you use the information that's collected during the ASAM, and you might get information from some of the items, and you identify the items ahead of time as a system to flag risk. That's what LA County is doing. So how is at-risk SUD determined part of medical necessity? We do know from research that there are these clinically supported risk factors that you can get from an assessment, right? Pharmacological, these include, are they early initiation? Are they using early, at early ages? What is their consumption patterns like? Are they using daily and frequently? Those are risk factors. Polysubstance use, are they using more than one substance? We know that that's a clinical indicator of risk, including tobacco. What is the route of administration? We know that's a clinical indicator for risk. If they're using more severe levels like smoking and injection, that's a risk flag. Have they had previous treatment before for alcohol or drugs? That's another risk indicator. So depending in this area of dimension, I believe dimension 1 of the ASAM, you would be able to collect risk factors that you'd be able to then adequately satisfy your documentation that they don't meet DSM-5 criteria, but they meet risk criteria from ASAM that include some of these clinical risk indicators. Biomedical would be dimension 2, areas that are supported under assessment for risk for youth would be chronic pain. If they're suffering from any chronic pain, if they're using substances to deal with medical health issues, like maybe sleep. They have sleep problems, maybe they've gotten into an accident before. This would be a red flag or indicator of risk. Dimension 3, it would be psychological. Or they have any mental health issues or symptoms in general, like low self-esteem. They would have any health issues around maybe trauma, victimization, any weight issues, and they are these are red flags if you remember the dysregulation pathway. Usually these red flags are going to be tied to substance use behaviors for self-medication. So exploring that relationship during dimension 3 is important. They might not meet DSM-5 criteria, but they might have some risk here early on that serves the at-risk definition. Then there's risk behaviors. This is also in dimension 3, right? Cognitive, behavioral, and emotional. This is the behavioral piece that you're going to want to get at. If they have gang involvement, if they have bullying history, if they have any risky sexual behaviors that are occurring that might be linked to some of the mental health, maybe trauma, victimization, these are risk behaviors that also put one at risk for continued substance use issues. And then in the social dimension 5, right, what are their stressors? This is the continued problem potential. In the ASAM tool, it asks about stressors or triggers in their life that might contribute to substance use, like problems with their family or peers or not fitting in, maybe not doing well in school or having a learning disability or IEP. Any pressures like this that might contribute to continued use, that's a risk factor. And then environmental, this is dimension 6 of ASAM. This is any family that's used, if there's any family use in the home, if there's peer use, those are red flags. If the family is threatening, if they have an unsafe or threatening environment, that's a red flag as well. If they have lack of social support, if they're not involved in extracurricular activities at school or pro-social behaviors, that's a red flag, because if dimension 1 they're using and they're not engaging in any pro-social behaviors like wellness behaviors, that's a red flag in that area, because we know that research shows that if they're engaging in pro-social behaviors, that might offset some of the risk there. But if they're not engaging in pro-social and they're engaging in substance use, not engaging in extracurricular or pro-social is a red flag. It becomes a risk factor. Okay. So implications for your youth system. How should service models be changed to address at-risk youth? We are going to address how you take this information then if they're at risk and what kind of services are more appropriate versus if they have a disorder, what services are more appropriate there. So I went only almost 2 hours, and I guess we'll save some time for discussion. But before I do, I wanted to point out that there's a lot of resources. I talked about the principles of effective treatment and the importance of screening and interventions. You can get that here at NIDA in Principles of Adolescent Substance Use Disorder Treatment. I think that's important to have to support this notion of interventions. We talked about screening and interventions. ATTC Network provides a wealth of resources on the screeners around the CRAFT and the S2BI. They also provide a lot of resources around risk reduction and what are brief interventions that we'll talk about next time. Another resource would be SAMHSA. I talked about this tip early on. treatment improvement protocols. They're free. You can download them. Sometimes they're not available to send out to you because they haven't been replenished, but they will be. They constantly replenish these, so you can either download the one that's online, or you can ask for these to be sent to your system of care in bulk. They will send them. And then you should read up more on EPSDT benefit. There's some information there on that link. And then ASAM. You know, we talked about ASAM and using the dimensions. There's important information there around risk reductions or early interventions that are important to understand. We'll talk about that. And then the CDC has a lot of information around, and NIAAA, around resources you can start to use around this notion of risk and substance use as a health issue, particularly NIAAA with drinking. We know adolescents are binge drinkers usually. They drink a lot. What is a standard drink? What does consumption patterns look like? We do need to become more and more familiar with drinking as an at-risk issue versus as a treatment issue. And I think expanding the definition to at-risk versus disorder opens up opportunity to be more resourceful around substance use being risk, like marijuana patterns or drinking patterns. And so really visiting NIAAA for that information I think is important to do. So next time we're going to be talking about how are substance use risks and disorders addressed under a developmental framework, but today we kind of just covered the developmental trajectory, the framework, this notion of medical necessity now including at risk, and how to be mindful of, as a system, of how to flag risk indicators should DSM-5 not be there. So now I'm going to open it up to questions and comments from you all at Shasta County.
Rachel, this is Diana. I just want to jump back really quick to your comments on the screening tool. Together we were going to work, or you and I were going to have further discussion on the screening tool pieces, and then we were going to bring it to our larger collaborative group here in Shasta County to take a look at and give feedback, because we will have a single youth screening tool that that'll be one of the trainings that you will have the opportunity to do with not only providers, but hopefully some education folks and medical providers and some prevention folks here in our community.
That's great. Thanks for reminding me about that. We're going to be doing a lot of work out in Shasta County, so this is just to kind of give you the big picture as to why efforts are needed to really tailor a tool, a screening tool that makes sense for your county. And we're going to be doing that over the next month or two or soon, and then provide you with an in-person training on really using these tools with case studies, as well as the ASAM assessment and really nuancing what at-risk means for that. I gave you a glimpse of some examples, but that's another area we're going to be working on with your folks out there to really better prepare you.
So this is Kathy. I'm from Public Health. I have a question about the screening. Where have you seen screening be most successful, in what organization? Or
that's a good question, Kathy. You know, it really has been successful, I think, at centralized places. There's a movement towards universal screening as a system in general, and I don't know if Shasta County has these places, but you know, there's pros and cons with that. So the pro is that you can then provide, as a system, you can work with other providers in mental health, in school settings, and in justice settings, a place to direct youth to before the treatment agency. So you can direct them to a centralized screening kind of hub, like telephonic. And under the waiver, what that is the beneficiary access line. And so you can start to grow and expand the beneficiary access line with the screening, where you would have that tied to either a centralized source, or each provider becomes that beneficiary access line where they can call in depending on the number, or it's a line where it's linked up to all kind of agencies, because you're a small county. So there's pluses with that, because then it provides a kind of streamlined, consistent resource across systems, and it opens up the door for care coordination and system integration. However, there's a downfall to that, because youth don't like to, or people don't like, youth in particular, and parents, they don't like to call places. They want to just go and have, like, they want to just walk in or go to an agency directly. And so because of the screening and not getting youth on the phone, you might just get a parent or a provider on the phone. You're not going to really have rapport or any kind of engagement with the youth during that route, right? So that's a minus. So then I would also suggest to have screening implemented at the agency level as within the protocol of intake, where it happens where you're going to have a brief screener and as an engagement piece that happens with other intake forms, where you're going to say, okay, well, as part of routine screening, we're going to collect some information around your general health and wellness behaviors, as well as substance use, and to see what's going on there. And, you know, some providers are saying, well, can we just stop at screener because it's flagging risk and just categorize those youth as at risk? No, because there's some issues there, you're going to want to then engage them in a full assessment and say, okay, and that might be at another visit, and because we know that there's issues with youth interviewing them for such a long time with engagement and issues of the sort. So using it at the agency level is an important first step to engage and kind of just flag risk, and then set up another appointment where they're going to come in and you're going to do an assessment to really more explore risk with youth. You can also, the other area is field-based services. So we're seeing that the screeners are being done where your folks are being co-located, let's say at school sites or at court sites or at justice settings or at mental health settings, right? And so they work as more of a navigator kind of field-based model where you can screen there. And then, so 3 different places. Did that answer your question?
It did. Thanks so much.
Okay.
Any other questions?
Are there other questions or comments or?
I know that with Shasta County, we have a strategic plan that we spent some time on, and it was identified that harmful substance use is something as Health and Human Services agency that all 5 branches want to make sure that they focus on. And so with the piece of that, that's why well, that's number 1, the reason for our collaborative. But then number 2, the reason for selecting a screening tool that's going to address youth issues differently than an adult screening tool. And then as much as possible, getting it out into the public so that whether it is the counselor at the school doing the screening tool or it is their primary care physician doing the screening tool, that is happening for our youth so we can address those who are at risk with the level of treatment that they need without having it be that primary prevention. And this is what got me last November when I heard you speak, is without it being that primary prevention or the actual, treatment for addiction or dependency, but really that secondary prevention piece of whether it is that fitting in, whether it's covering up the trauma, whether it's just experimentation, how do we access those youth and address it before they end up in that severe cases?
Right. No, that's great. And, you know, with medical necessity, under EPSDT, it's important to recognize that benefit is available from the waiver standard and as a system, and it's available for youth who continue to meet medical necessity. So let's say you do a brief intervention, let's say, or a risk reduction intervention in these settings, and then you, in school settings or wherever it may be, this doesn't mean that they're done, right? This means that you can continue to where did I have the definition of EPSDT? That means you can continue to work and continue to do brief intervention should they meet medical necessity, right? So this whole notion of this ongoing intervention work, I think, is critical, and not just operating as if we vaccine them, if you will. We've immunized them against substance, alcohol, and drug use, and really operating around on a continuum framework that falls prevention, intervention, and treatment, because should they get intervention, then they would benefit from prevention, right? And continuing to help them not use or continue to reduce their risk and not use, versus, you know, oh, I'm just going to do prevention or treatment, and we miss this opportunity to explore risk and engage youth individually in a way that could be a lot more effective. When we are going to do treatment, should we have to assess them and maybe move them up? Maybe if they're at risk and, you know, they need more, then you can put them at low-level outpatient treatment under brief intervention services, but just have lower intensity services, and really change your continuum from being 1.0, like LA County did, to 1.0 AR at risk. So they're actually giving them treatment, but not like the intense treatment of the 6 hours or the 9 hours. They've operationalized their system where they're giving them a smaller amount of services that are therapeutic, but they're addressing risk, right? And so we're going to be working with you all around that and what that looks like, and I think it's very promising.
Right, and that's that piece where in the spring, I know that there are many mental health clinicians that are looking forward to those trainings so that they have a deeper understanding of those interventions, because that's where that work will really come into play.
That's right. That's right. And I think the other work, Diana, or maybe that was Amber. Was that you, Diana?
Yes, Diana.
Oh, good. The other piece is working, one thing that I think is important to do, too, is really to ensure that your assessment has language that's developmentally appropriate, right? So this notion of language and being sensitive to language, I didn't include that, and I think that was one area that I forgot to include, was really tailoring, like, youth don't like, they're not very receptive to words like relapse or words, because they are just using, they've never quit, so why think they're going to relapse, right? Or recovery. This is an adult term, recovery. Youth, for a lot more times than not, they're not in recovery, and they view it as just lifestyle change. And so really, or they don't like the word treatment, right, because it's very stigmatizing, it's very shaming. So rather than use the word treatment, we call it services. You know, we're going to provide you therapeutic services in general versus we're going to provide you treatment. So I think really being mindful, and we're going to talk about that next time, of when we start implementing how we deal with at-risk or therapeutic services, is really being mindful of language.
Right, and I think that's another thing, because I asked one of the providers in the room, about the ASAM, and it was something that we moved forward with about a year ago in our county, may have been a little bit longer ago than that, but about a year ago we moved forward with mandating use of the ASAM criteria to determine the medical necessity piece. But I think it'll be something that we have to look at, and we'll have to revamp it so that it does have youth language in it, and not use the same ASAM. I'm going to say, you kind of use that summary page. We can't have an ASAM that has the same type of information on it, yes, that one, for adults and youth. They do need to look a little bit different. Our language needs to be different around it. That was something else that I really appreciated about you speaking to a year ago when I heard you, is really treating youth as youth and not as adults. So. Yes,
that's right. And so this is an area that I'm really excited to work with your county on. We did a lot of work in LA County around this area, and really adapting the ASAM tool away from the adult tool that's, you know, available. But frankly, we don't have one from ASAM around adolescents. This is an underdeveloped area. And so there's opportunity for counties and systems to create and to adapt in ways that make sense developmentally. And so what we did in LA County was we did provide technical assistance that we would love to do at Shasta, and I think, Diana, this is one of the things you really want to do is, yeah, change some language and come up with some items that really would allow for speaking more towards the developmental nuances with youth and really help you identify more of these risk factors. And so adding some of those questions in, either embedding them directly in or having a tool at the end. I do think shorter is better, so not having like 2 additional or 3 additional tools. So this is something we could definitely work on as our next steps, because I do think it's important to do that as well.
Great.
Rachel, it's Kathy again from Public Health. In your in your presentation, you talked about tailored risk messaging for prevention. Can you speak a little bit more about that and what that might look like?
Yes, and so I was going to do that next time.
Okay, that's fine. I'll be here next time.
Well, I'll do that a little bit now because I think it's important as we begin to do interventions and treatment, we have to use risk messaging that incorporate risk factors and protective factors. And so even for prevention, and so the example I'm going to give next time is around marijuana and what types of activities we can do as providers where we engage them in risk reduction activities around, like giving them an article around marijuana and the brain and simply giving them an activity to read it, maybe during the intervention, and they read it, it's a brief read, and then we say, well, what do you think about that? Because then it shifts the conversation towards risk versus, you know, you identified, you're using marijuana and you're at risk for a disorder. They're going to be like, well, no, marijuana is legal and it's a medicine and it's healthy, and so I'm not going to listen to you try and tell me that it's bad. Whereas you're going to want to tailor your messaging and shift it to, and they also have risk perceptions. You're going to probably want to give them an article or something like that to do with you, where then you have a dialogue around risk that is led by, you know, evidence and science and clinical support than you just having to be like, well, drugs are bad, you know, marijuana is bad. That's an example, Kathy.
Okay, great, thank you.
And Kathy, and just because I think I heard this from you last time, and I think Public Health does do a good job of, we've got some pamphlets out that talk about just the facts that are focused for kids. Right. And literally with a group of teenagers, I gave this out, not of my own thinking, I actually got it from Rachel listening to her, but gave this out to a group of teens, and it became a whole different dialogue as they began to talk about it versus this drugs are bad. So I think Public Health is right doing what they need to do in regards to the facts, facts around marijuana, facts around drinking, facts around tobacco use. My own daughter was fascinated with your tobacco use facts.
Oh, okay.
So I think that things like that are important for the teenagers.
Yeah, and I think, thanks for that, Diana. And Kathy, as Diana was talking from a primary prevention standpoint, I do think it's important to take information and messaging, information that we know around risk that is occurring, and really channel them into prevention messages where, you know, the campaigns are around know your risk, or, you know, language around risk is important. I think in drug education and facts about drugs are very important, but those can be incorporated into more of campaigns that really are directed towards risk and attitudes and values, particularly in the era where we're up against the social currents of pro-social marijuana and pro-social alcohol, and, you know, this whole notion of drink responsibly, and what does use responsibly mean for an adolescent. And I think really channeling that into prevention messages is, I think, critical. for them, because they are receptive to this kind of information around being able to make their choices. If you recall, early on I talk about this stuff where, you know, it's a self-focused age, it's an age of instability, it's an age of possibilities, this whole age of possibilities where they're optimistic. They view the future like they can use they want to use alcohol and drugs, they want to use what's out there, they see it in the media, they hear it in the radio, you know, they're very desensitized to it, and it's actually seen in a positive light. So how do we play up against these developmental current that's occurring? And I think the important piece is risk. They will listen to risk language. They won't listen to problem language, right, or disease language. So I think we need to be mindful of that in our prevention messaging with them is something to keep in mind. But we'll talk more about it next time.
Great, thank you.
Yeah.
Rachel, I have a question I'm curious about. Now, my name's Barbara. I'm with a community-based organization where I see youth all the time, but not the families all that often. So I'm curious, where does it come in to play in the groups you've been working with so far, the counties you've been with? Where does the piece come in of families and parents especially needing any type of authorization? Like, is that necessary for screenings? Where does that come in?
That's a good question. What we're going to cover next time in the earlier piece of next webinar is this area of parental inclusion and where parents fit in. And, you know, under the Drug Medi-Cal waiver, there's no kind of mandate around the inclusion of family. There's no guidance on the inclusion of family during assessment. So working with the counties, and in LA County in particular, there are some providers who include family during the assessment. And what does that look like, you know, with understanding medical necessity and understanding risk? There isn't an ASAM tool for families, but what some LA County, and I think it's only 2 providers, and there's not a mandate, though, for including family. This might be something different Shasta does, but they give the parents the same tool, the ASAM tool, and they have them fill out certain sections of it. And so if you look at the ASAM dimensions here, they'll have them fill out stuff around their health, like Dimension 2 and Dimension 3 and Dimension 6, right? So what areas or what information or relevant information do you need to get maybe from the parents and from the family that you want to collect? You don't have to get the full ASAM, but you want to ask them certain information around those dimensions. So what we've seen is some providers, and we've encouraged them to kind of pull out the information from the ASAM to use with families when the families show up, because, you know, like you just mentioned, and we're going to be talking about this when you include families in the service. You know, if they come referred, like if we talked about, I think Kathy asked earlier, where does screening take place, or should it take place? Well, at the schools, you don't have parents and you're not screening parents. At the agency level, usually providers or the legal system, they're not referring parents. They're referring the kid who got in trouble. And so that's a system challenge as a whole. And then when they do come into your setting, sometimes the parents come, but then there's like, we don't want our parents to know, and there's this whole, like in California, there's this under Drug Medi-Cal, there's a confidentiality waiver where they get to sign away their parents' ability to know that they're receiving services. However, in California, should they use that Drug Medi-Cal consent program, the youth consent program, they are no longer eligible for EPSDT services. So that's important to know as a provider, that you don't want to not include the parents, because then you're not going to be able to include the services, the full spectrum of services that you're open to under the waiver, like risk reduction and like all these other ones. So I think including, maybe if you include them early on in the assessment piece, I don't know the practice at Shasta, I would then encourage using aspects of the ASAM dimension where you get important, relevant information. Maybe it's the administrative piece where it asks them about their insurance and it asks them, you know, where they live and all that stuff. Maybe you get that from the family and not necessarily the youth. But then in the treatment models that we're going to talk about next time, I am going to include family because it is a best practice to include family in services at all levels. So I hope that answered your question.
It did, thank you.
Okay.
Anybody else have any questions, comments? Rachel, thank you very much.
Yeah, this was great. Thank you, guys. And I look forward to next Tuesday?
Next Tuesday, yes, the 14th.
Next Tuesday, we will be live, and we will be covering the next aspect, which has to do with Part 2, which is addressing substance use under a developmental framework. So, again, getting into this notion of risk versus diagnosis, and then how to effectively use the screening tools a little bit more. I'll get into maybe include the parent practice there. I think I cover there. And then as well as then how to what is appropriate response, and the importance of language, the importance of what are effective interventions that are available for risk, and then what are some treatment kind of models. And I think with that one, we are going to go the full 3 hours just because there's a lot more information there. So I look forward to next Tuesday.
Thank you very much.
Thank you.
Bye-bye.
Bye.
Monday, and then next week. Are you